Yeah, welcome to our second episode in Switzerland. My name is Melvin Bos, physiotherapist, manual therapist, and board member of the Dutch Association for Manual Therapy. Before we go into the depth of the theme or the subject, I would like to do an introduction, give them the room and space to introduce themselves. So first of all, Peter, can you tell who you are?
Yep, my name is Peter O'Sullivan. I'm originally from New Zealand, trained as a physio there, went to Australia to train as a manual therapist, and then realised I needed to do further study. So I ended up doing a PhD, and pretty much my whole career has been half-time working in the clinic and half-time working with people with disabling pain, which has really massively informed my journey, I think, is in the evolution of like really learning to develop skills and test them to better support people who live with chronic pain.
All right, and then the second one?
Yes, so my name is Nathan Hutting from the Netherlands. I'm also a manual therapist, and my journey also had a kind of new road because I'm now mainly doing research in self-management, patient-centered care. And then tomorrow after the conference, I will be the new vice president of IFOMPT, so I also look forward to shaping the future of manual therapy in IFOMPT.
Yeah, I would like to congratulate Nathan, you as well, for your nomination and the position you have achieved.
Thank you.
Within IFOMPT.
Yeah, congratulations.
Thank you.
For you, Peter, what do you want to talk about for today? What's interesting to hear from the listeners?
Ha!
So it's an open
cool.
start.
Well, it's interesting. It's a great question. I think we, as a clinical community, I think we give up we lose hope with people with chronic pain. I think we have people come into our clinic and we see their pain behaviours, we see their distress, and we look at their history and we lose hope. And if we don't have hope, they won't have hope. And I think what we know about the current health system is that we know that back pain is the leading burden of disability in the world. We know that there are many people in our communities who we haven't helped, who are just left abandoned, and that's not okay. And I think without realising it, our health systems have created a lot of that problem, and we need different ways to care for those people, to support them to get their lives back.
Yeah, that's a good one. Nathan?
Yeah, so I first want to ask a question to you, Peter. So,
yeah, no worries.
So this is the manual therapy conference.
Yeah.
And you already know.
And I am a manual therapist.
Yeah.
Right?
So how do you see, also in your approach in the CFT, how do you see manual therapy? How can you integrate that? Do you think it's...
So it's interesting because we had a lot of anxiety amongst the clinicians who were in the Restore trial because they were like, can we use manual therapy? And we're like, no, you can't. There was a reason for it because we had these movement sensors on, and that was perfect because it took that away because we had to have these movement sensors on. They couldn't be pushing and poking their back, and I wanted that because I just wanted it to be clear that this is about empowering people for self-management. And I think as a manual therapist, we have this belief that we need to do manual therapy for people to get better. And I have a view as a manual therapist, if I can avoid it, I will. It's almost like if I can not do manual therapy, to me it's a faster pathway of empowering people to self-manage than getting caught in this conversation about me doing something to you and it's the therapist that's creating the effect, rather than saying, you know what, you're in charge of this. We're going to teach you the skills to manage your pain and to get your life back. Now, it's not to say I would never use it in clinical practice, but the people in our trial were highly disabled. They had lots of manual therapy before, lots of different treatments, and they hadn't worked. So it didn't make a lot of sense that you'd give them more of what hadn't worked either.
I think it's really dependent on the patient characteristics.
Of course it is.
For some people, you need manual therapy. For other people, you need other approaches.
We don't actually know that, though. We say they need manual therapy, but what data do we have to support that they actually need manual therapy?
Yeah, so how do you decide that?
Well, I think it's about the patient's agenda, not our agenda. Because often what comes is it becomes our agenda. We think they need manual therapy. Where actually we kind of one of the key things that we do is we don't say to patients, what do you expect? from the treatment, we go, what are your goals? What are your goals? And often we ask about short and long-term goals, and patients often talk about their short-term goals as, I think I want some pain relief. I get that. But the long-term goals are almost invariably is I want my life back. And you go, what's life back look like? It's playing with my kids, it's getting back to work, it's getting confidence in my body, it's losing this fear that I have. Now, you could use, we often, manual therapy is a means of creating some pain relief. I get it, and I've done it, and I have those skills. But we forget the power of behavioural learning as a mechanism of giving pain relief, where the patient is empowered to go, shit, that's something I can do myself. I can do it at home. If I'm in pain, I have these tools in my toolkit that I don't have to rely on coming in for you to do something to me. So if I can give the patient that, it is so much more empowering.
Yeah.
But if they said to me, look, mate, I really feel like you need to do something to me, then I would have a conversation with them about that. And if it was appropriate, of course, I would work with them.
Yes, so how do you do that with the patient expectations? If they have really some biomechanical views and they expect manual therapy, how can you turn that around?
Oh, I'm very honest. I'll say to them, look, you have some restriction in movement. That's about protective muscle guarding. So I can work on your body and give you strategies to relax your body and feel safer. But the key thing you need to know is this is short-lived. This is not a long-term thing. This is only a pathway to you to build your own confidence in your body so that you can take control of this. So we have to be really clear on our messaging and about the role that manual therapy has around the journey of a patient. Because the last thing I want to do with someone who's frightened with low self-efficacy is for them to create a dependence on me. And I promise you, I've done it in the past. I've had people who just are the revolving door of coming back with the same pain and they expect me to do something. Yeah. And that is a horrible feeling as a clinician.
You mentioned before, that was interesting as well, about the motivation, belief from the manual therapist.
Yeah, massively.
Because you see a lot of scientific evidence with the belief of the therapist is evolving in a negatively way.
Yeah.
But how can you tackle this one for yourself as a manual therapist?
Yeah, it's interesting. We had, in our trial, we had a training phase of the trial where we took a group of 18 physios and we trained them up in the CFT approach. And there was this anxiety amongst the clinicians to go, but they will want hands-on treatment. We had about 70 patients, or 70 to 80 patients that we saw, people with really disabling back pain, who we saw in the training phase where we coached and mentored the patients working, the therapists working with the patients. Only one of the 80, asked for hands-on treatment, and it was a healthcare practitioner. And that was really, really stunning for the clinicians, because they're like, they had a view. We asked the clinicians to explore the patient's goals, not to explore what they expected from treatment. And when the focus was on goals, it went away from this idea of, I want you to do something to me, more towards, these are my concerns and worries and fears and hopes, and this is my situation, and this is where I would like my journey to go. When that focus shifted, it was less about, are you going to do something to me, and more about, how can I get there?
So because I had this focus approach yesterday about self-management and self-management support, and in my opinion, because self-management, the origin is it's used in people with chronic populations, persistent complaints, and in my opinion, we should also use such an approach in people with acute or subacute
100%.
So is it also for CFT? Can you also use that
you
approach?
Bet. Well, if you think of acute pain, so this is where I think we often forget that the majority of acute back pain is a recurrence of a pain problem. It's not really the first time. We know that, I think in the studies show like 75% of people who present even to ED, emergency departments, they've had the pain before. So it's like a recurrence of it's like asthma. If we think of back pain as more of a chronic condition like asthma, that can have a flare-up. And we know that the predictors of flare-up are things like inactivity, stress, run down, tired, not injury. then it makes total sense that we use this approach.
And I also think the first encounter is very important because
Critical.
when people come to you, you don't know if they will have persistent complaints or recurrences.
Yeah.
So if you do only the passive treatments, then you make them independent already,
Yeah,
and they expect
100%.
it again and again. So
Yeah.
I fully
Yeah,
agree on that as well.
100%.
But it's still challenging to change
It
the
is.
profession.
And
of
look,
course.
that's part of us as our identity. Like, and that was and has been my identity. You know, I was and probably still are, a skilled manual therapist. I used to teach manual therapy. I could crack any bone in your back, but I very use that tool now because of the people I see, and mainly because they've had it and it didn't work. And so why would we be giving them more of the same thing that hasn't worked for them? And I think that's where we have to deeply listen to the patient's story and go, if they come to you, or if you're a clinician and they're coming back and they're non-responding, we have to do something different. I'm not against manual therapy, but I'm against some of the messaging and the passive dependence that often goes with manual therapy, the revolving door. Instead of saying, you know what, people present to us, and yeah, we have tools that can give them pain relief, but we actually have other tools where we can teach them to create their own pain relief. I prefer that as that sits well with my values.
It's very interesting, Peter. Is there something else for the manual therapy as well, just to look outside of your clinical room, to local governments, to do a collaboration and creating a context for the patient?
Could you explain that?
Yeah, it's just like when there's something, you mentioned before about the short term, right? With the hands-on intervention or something you're giving your patient, and it's more about setting your patient centered and getting to the long term, right?
Yeah.
But it's not only the manual therapist in the room who's treating or setting up the assessment with the patient, but how can you manage that one outside of your practice?
Yeah, also
with
the
your GP or with the local.
So also maybe
it's
the
really
patient believes in
important.
society.
Well,
society.
Yeah, 100%. Look, we don't get a lot of pushback from GPs on this approach. We get way more pushback from our own profession.
Yeah.
It's seen to be threatening people's businesses because it's like, well, we're teaching people to self-manage. That's like bad for business. Yeah. So there's a lot of pushback internally from our profession. And I'm like,
sure.
but we're dealing with a societal problem, right? So we will try and, we communicate with GPs or who else is in the health network. We will try and draw strengths from people's communities in terms of, for people who are particularly, disabled, we know that the partners often carry a burden as well. And so partnering with supported others to kind of walk the journey and to reinforce.
You want to create a contact, right?
100%.
Everywhere the patient
Absolutely.
is going on.
Yeah, 100%. And the other thing we do is we will link them to resources, share patient stories around people regaining hope, people who have been stuck, who have been through so much treatment, who are, given up, to actually build hope. We know hope is one of the key ingredients for change. If you don't have it, it's unlikely you'll walk that journey.
Maybe because you presented about the 3-year follow-up period of your trial, which shows great results. But you also mentioned that your team or the therapists were not in touch with the patients within that 3-year period.
Not that we know of.
Not yet.
So there was no treatment. There was no treatment after that.
And that's very surprising, maybe, because we know that sometimes follow-up is also important. But in this patient group, they were able to manage themselves.
Well, that's why the qualitative work was important, because there was one of the patients who was qualitative, and he was highly disabled before. He just said, "I don't know why you're contacting me because I don't have a back problem anymore." Yeah. Literally, it's like, why are you contacting me 12 months later? I don't have a problem anymore. It's not even there. Where others would say, yeah, it was a tough journey, but I'm good. And others are like, you know what? It was a really tough journey, and I still feel like I need some support. So we know everyone's pathway towards self-management is different. And we know that there are some people who are super vulnerable, who we may need to give additional support, and particularly around flare-up. So we put a lot of emphasis on personalising a pain flare-up plan for them to go, okay, these are the things that typically, in your story, have triggered a flare-up. And usually it's, I'm unwell, I'm stressed, I'm run down, there's other stuff, not sleeping well, bang, so, minor event triggers a flare-up. It's like, okay, so let's map a plan of what you're going to do if that happens. So
Yeah, you prepare them for the flare-ups.
100%. We're like, it will happen. Like it's like
definitely.
It's 100% almost certainty that this is not a cure for pain. It's about a way of managing your pain so you feel in control. So, if I've got a risk of heart disease, for example, then not smoking, regular physical activity, healthy diet, good sleep, manage my mental health is going to reduce my risk. In the same way, pain has similar risk profiles, if you think about it. And so getting people to understand the nature of pain and the various kind of non-structural drivers of pain was kind of like this light bulb moment for a lot of people of like, that makes total sense. It doesn't make sense if you think your back's damaged, but it makes total sense if you understand that the nervous is constantly in a space of fluctuation.
Do you think there's any difference between the management of those other chronic diseases like diabetes in comparison with pain?
Yeah, I do. I think, heart disease, for example, is often a silent disease where pain is an ever-present, highly noxious problem. Yeah. So it's a massive modifier of behavior. And I think that's why we got such great satisfaction is we literally gave people tools to reduce their pain. So that's hugely motivating. Like if you say, look, if you're re-engaging with movement and activity and it hurts you, but hey, here's a strategy of doing it where you hurt less, why wouldn't you do that? Where, take smoking, like the threat is in later life, right?
Yeah.
Or heart disease, the threat is like in your 60s and so those health behaviors in their 30s, you just kick them away. Where pain is like every day relentless, it's a very potent modifier of behavior.
You mentioned before the one with the fluctuation, right? So we should give them some knowledge for your patient.
100%.
How to manage it as well.
And personalize it.
What's the main thing which is causing this situation, you think? There's a lack of knowledge from the patient and everything else.
Yeah. So
how to manage it.
So if you think about the common beliefs around back pain in our community, and these are often shared by clinicians.
That's the problem.
Part of the problem. There's something biomechanically wrong with you, right? Or there's something structurally wrong with you, and we need to.
The healthcare creating it, you mean?
Yeah, massively. Our healthcare system creates
just not to interrupt you, because I have a back problem myself. I heard you have also some back problems in the past.
Yeah, you bet.
So I went to the neurosurgeon, and he said the neurosurgeon said you need surgery.
Yeah.
And it was 2.5 years ago, and I was thinking, if I would have been a patient with no knowledge, what would have happened to me?
Yeah.
It was so strange.
Yeah.
And now I have not had surgery yet, I feel quite well.
Yeah.
But that's so strange. People need really knowledge and skills and support.
Yeah,
so
100%.
That's
and that's where we need to really educate clinicians about pain. Is like and debunk myths. We've done heaps of research debunking the myths, the common myths.
And it even needs more responsibility, right, from the
Massive.
people working within.
Massive. We have so much responsibility for the messages we give, and the understanding we impart. And the other thing, I think we often as clinicians undervalue the importance of educating people. It is a pillar of good care. Like just spending the time to help people make sense of their own story is like critically important as one of the key pillars of good care. It's in every guideline, but clinicians often rush it. They don't write it down. It doesn't make sense. It's full of jargon. It's complicated.
Where are the chances to optimize the one with the good care? Is it within education to optimizing it?
Well, I think it's a combination of things. So, in the Restore trial, we said you need knowledge, you need skills, and that you need competency to hone those skills and adapt them to a whole variety of people. Like that's how we learn stuff, isn't it? Like you can't develop a skill without knowledge. Knowledge without a skill is useless, and if you can't adapt your skill to an individual, then it's kind of redundant. So it's kind of like any skill acquisition goes through that process, and every human being is different. They will present differently. They got different combinations of factors. So we need, a flexible framework to go, okay, pain is complex and it's multidimensional and it's all about the individual. What tools do we have to help us navigate that complexity to target?
This one is complex as well. This one is complex as well, to create a framework for the individual
It
patient.
sort of is, but it makes total sense. It's just because we've been brainwashed to think of pain as structural biomechanical, and we just have to get rid of that. Like, it could be structural, and so we don't dismiss structure, but we don't frighten people with stuff on a scan that we know is normal in pain-free populations and not predictive of future pain. Fractures, yeah. Malignancies, yeah. Quarter equina syndrome, yeah. Like disc prolapses with radiculopathy, if it correlates, yeah. Those things we know are important.
Okay, Nathan.
Yes, no. I was just thinking about also your result and showing good results with CFT. So I'm an advocate of self-management support. We also see in different trials also good results in low back pain from self-management support. What do you recommend? Should every physiotherapist be skilled in CFT, or are there also some other different approaches that could be helpful?
So I think, as I said in the presentation today, it's one approch. It's not the
you started
approach.
with that, yeah.
It's one approach, and it's an approach that's kind of emerged from the clinic, and is very supported by patients. So the lived experience of people with pain has really influenced that approach, and it's supported by evidence. So it's a approach, but there's no way. We would often say to people, the key thing is the destination, how you get there. Like if you're going to go to West Australia, right? You can take a boat. It might take you 3 months. You could go 30 hours via North America, or you could go a direct route via London. It's a hell of a long flight. It's a direct flight. Now, when it comes to the evidence, we're like, how much, because the nature of CFT is individualized. So some of the patients only had 3 sessions. That's all they needed. Others had more. Now, if you go, okay, so how does it stack up for cost, accessibility, training, and outcome? How does it stack up? Because that's how we would look at to go, how does that weigh up? And is it transferable into different cultural, settings and care settings? And the other things that we're doing now is to look at how transferable that is. But what we're here, we've run trials in different countries, and we are doing more of that now because we're really interested in that. But no, we would never say you have to do this, but we would say, what is the essence of it? We'd look at that, like what are the key things? And I sat through a number of sessions yesterday, which really were just pointing straight at the intervention that we had tested in the Restore trial. So there's mounting evidence outside our group that's pointing that the kinds of things that we deliver in that intervention, 1, they make sense, 2, they're evidence-based, and 3, they're meaningful for patients, and 4, clinicians like it as well.
Yeah, so I think that the key message might be individualized treatment is also very important, because that is what you also do in the CFT approach.
Yeah, it is.
And that's maybe sometimes also often maybe neglected, because I think that manual therapists offer the same approach to every patient, and of course they should involve the patient in the decision making and goal setting.
Yeah.
But I think we can do a lot better with
100%. And it's called patient centeredness. It's not our agenda; it's the patient's agenda. That's the most important. It's like dropping our ego and going, how can I best support you to reach your goals? And I think we have to be really honest with ourselves as manual therapists to go, in reality, COVID was really interesting because we flipped our practice in 3 days into a telepractice. My list didn't change at all. And why? Because my patients knew I could deliver this intervention online. Mm-hmm. But the manual therapist practice completely died because the patient's like, why would I talk to you via telehealth? Because you can't treat me. Yeah. So, and that was really telling, I think. And, there was something really interesting about the telehealth thing where we can coach people, we can guide people, and we could do it online, we can do it in person. So now, since COVID came, I'm working with people from all over the country.
Yeah, that one is very interesting, because is this a confirmation of the practice to look on a different way of
100%
reaching? And So the ones who are following up during COVID were the best ones, I think, with the new style or different way of approach.
And the patients
long-term,
got
right?
it because patients weren't going, well, I'm not coming in because you can't crack my back. They were like, I get how you work and I get how you can deliver that through Zoom.
Did it affect the relationship? Because of course the therapeutic relationship is very important. Do you think it can be the same online in comparison with face to face?
You know, I think it was deeply comforting for people because they were socially isolated. So that was one means of connection. We had a lot of people who were old, who had other health comorbidities, who were terrified of human interaction, and we were running group exercise programs online to support them in their homes. So that was really comforting for them to have a sense of connectivity with another person because they were feeling alone.
Yeah, and I think nowadays you still offer that distance approach, online approach to other people from Australia, because Australia is of course a very big country, so it's very helpful. Yeah. But I think the people from Perth, they come to your visit, or do you also have people who prefer and they live in the area do online?
But you know, it's interesting.
Good question, Nathan.
No, and I thought a lot about this. Like after the open up, we are social animals, right? We are social animals, and the majority of people just wanted to connect. Now, and I think to highlight this, we use hands-on with CFT. It's not hands-off. We use it to facilitate, to give feedback, to show people where tension is in their body, where they're breathing, to guide them. It is deeply hands-on, but it's not about providing passive therapies. And I think that's where people get confused.
Well, what is the key aspect for planning the patient with you in your room instead of online? Well, what's the main element for?
It's just a different level of communication, isn't it? Like, you know yourself. Like, if I was doing this talk today via Zoom, it's just a bit more of a gap where, you know, I can see your face, you know.
So it's more like the non-verbal communication.
Yeah, all of those, which we know non-verbal is so powerful as a tool of communication. It just you know, it's human connectivity. We are social animals. And, you know, I was interested in the idea of, you know, an app giving you direction. And look, I kind of get that for simple cases, it would just sort a lot of stuff out. But for really complex, disabled people, they can't read a brochure and make sense of their pain. An app won't do that. There's something about that deep connection with another human being that creates something that an app can't create. That's my belief.
So it's a good one for all the patients maybe, but there are some additional benefits for doing online with the distance and everything
100%
around it.
Yeah,
but
100%.
I think we should also take in consideration health literacy, because not all people are able to use apps or those kind of things.
100%, yeah.
In your population that you use in your trials, how did you assess people for health literacy, and is it possible for all health literacy levels to?
So we taught, because it's a patient-centered approach, we didn't give generic education. It's about using the story and the words of the person to kind of make sense of their own story, right? So it's at their level. It's using their words and, you know, using metaphors that resonate in their life. So that's the person-centeredness. We deliberately in the trial recruited people from a diversity of areas. So we targeted low socioeconomic areas and middle and higher because we wanted to get a broad spread. And that was important for us as well.
Do you got another question on this subject, Nathan?
No, so it's...
What do you experience for today on, Peter? The atmosphere here on the Congress?
Oh, look, it's just been really motivating, actually. I've been really surprised the upside. Look, you know, I was reflecting actually this morning. The first conference was I spoke at IFOMPT. It's the third time I've been invited to speak, which is, you know, like it's a huge honour. And at the first conference, I think I talked about spinal instability. I'm pretty sure. I was trying to remember. It's 2000. Pretty sure. Or maybe it was around subgrouping. The second conference was in Quebec. And it was just after I'd published editorial on BJSM, which was really to just put out there that a lot of the stuff I talked about and the stuff I published, I didn't believe in anymore. And I don't know if you know the movie Men in Black, but you know the Equalizer, which makes people forget stuff. So I played a video of the Equalizer to go, yeah, I published all this stuff, but look at this, and like now you don't remember it. But that's part of my journey, I think, and I think it's a journey of our professions as well, of coming to a conference now where there's this really focus on the individual, a focus on what's important for a patient. How do we meet this massive burden of disease in our community around chronic health problems? We need different solutions. We need innovation. We need empowerment models. And it's a really big problem.
Is this one of the big changes as well with the first session? Have you experienced right then and now?
I've loved sitting through all these sessions. I mean, obviously there are lots of sessions I haven't been able to get to, but there's a real sense of a new direction, I think, which gives me great hope, actually. And there's a lot of commonality, and I don't think I've seen that in a conference before. I've often seen these kind of silos battling each other. I haven't felt that or seen that. Now, whether they exist, I haven't seen it.
Interesting.
I don't know. What are your thoughts,
Yeah, Nathan?
Yes, so I think it's really also here, the theme is crossing bridges. So also in manual therapy, we're crossing bridges. And I also think that also when I was elected for vice president, I also said in my statement, I want to keep the good things because patients value manual therapy. So we should keep the good things, but we should also provide contemporary musculoskeletal care and integrating these within each other. And I think that is the future, and that's not easy because we can want that, but of course implementation is always the challenge.
Yeah, it is.
To get it through all the manual therapists in the world.
Yeah,
but I think that's the way to go, integrating those concepts. And I think we are on a good way, and this conference is really a good example of that. Many interesting topics that are really about contemporary musculoskeletal care. But yeah, here are there are 1,700 people here, but we have many manual therapists, manual physiotherapists. So we do our best to get the message out, I guess, and that's the challenge for the future.
It is. Yeah, agreed.
The session you did today as well, Peter. Are there some other speakers you're interested in to follow today, or?
Well, to be honest with you, I'm so busy today. I don't think
Flying
I'll be able to
off
sit in
today.
any of them. So I've got a Q&A in a minute, and I'm sitting in another session which is around patient-centered care, which is an area I have great interest in.
But it's all live, right? You're scheduled live today.
Yeah.
It's not online.
Yeah.
All right. And you, Nathan? Or what's your planning for today?
Yeah, I need to share a session later this afternoon, and furthermore, no other sessions today. I have a workshop tomorrow, so maybe do some preparation for that one as well. And then, tomorrow is already the last day of the conference, so then...
Exactly.
Yeah.
All right, now we're heading to the final phase of this podcast. So I think it's good for the listeners to get a take-home message for both of you, beginning with Nathan and after Peter.
I think make sure you update your knowledge and skills. Do courses, read a little bit scientific literature, but also I think for the professional organizations, make sure that the evidence also goes out to all your members, because not all physiotherapists, manual therapists have the time to read all these scientific publications, and that's really, they should be updated about the contemporary knowledge, of course. So that's a task, a duty that we have all together. But I think it's really, be interested, don't be afraid of change. You gave a good example, you changed in your career, and I think we should all be open for change.
Yeah. Look, I suppose I come back to the people with lived experience with pain to go, that's who we should be really focusing on, is people in our communities who are disabled and distressed and, feel like they've lost hope. To go, what are the skills that I need? Communication skills, empowerment skills, motivational techniques. What are the skills that I need to support people, to empower them to get their life back? That if you flip it the other way, to go, actually, it's not about me and my, there is a knowledge part on our part, but actually, what are the skills that I need to help that person tomorrow? That's such an important.
It's starting over to manual therapist itself as a beginning.
Yeah. Sorry, say that again.
Yeah, step one is to look at you as a therapist as well.
Yeah,
first.
yeah. But the most important thing, like our agenda shouldn't be about our identity. Our agenda should be about the people we serve and to help them reach their goals. And if the tools in our toolkit can do that, that's great. But if we're not getting there, we need more tools in our toolkit and different skills. And that's the journey that I've walked as a clinician, of realizing that my tools are inadequate to adequately support the people I work with. And that's my mission. Like, really our great interest is to create opportunities to teach people, upskill clinicians and build broader skills to deliver better care for people. And that's why we, have the restorebackpain.com website, and we have an interest in supporting clinicians all around the world to develop some of those skills. So we kind of want to create a space where people can go to it and it's a trusted place to support clinicians and people with pain, because the internet is awash with stuff, and it's hard to navigate that space.
Nathan, do you've got any tips and tricks for places to go online for?
Go to the IFOMPT website.
That's the best one. I would like to do a special thanks for you, Peter Sullivan, as well,
pleasure.
for joining for this podcast. Interesting to do it in Switzerland as well. And I would like to thank our new Vice President Nathan for next week, I think.
Yes, after the conference. After the conference, I will start.
And especially for IFOMPT as well, for giving us the opportunity as Dutch Association for Manual Therapy to record these podcasts for these events. So, and thanks to all the listeners as well. Have a nice day.
Thank you.